How does a patient, what qualities does a patient have to see in a doctor to decide that he is the guy?
That's a very difficult question, right? Lifespan, how much do you think now? In the
Doctors are dying early.
So the lifespan in India, the doctors, is around 55 to 60 years. Average life. Horrible, right? Plan to move back to India. Certainly, Hyderabad is my hometown and I would love to be here. I would not go anywhere else. Welcome to AIG Orthopaedics, Trauma and Sports Medicine podcast series. I'm Dr. Srinivas Thati, Director and Head of the Department of Trauma and Orthopaedics at AIG Hospitals, Gachipoli. I'm joined with my colleague, Senior Spine Surgeon, Dr. Kalyan Varma. Today, we are going to discuss about orthopedic surgery, the practice of orthopedic surgery in India, and training in orthopedic surgery. This is for my friends, people who would like to know about orthopedic surgery and how you can get trained and how you can set up your practice not only in India, even if you want to go across the world. So, Kalyan, welcome to the podcast series.
Thank you so much.
So, as an orthopedic surgeon, please tell me, what do you think the current training is and how is it different in India compared to rest of the world?
So I would say it is very, very different in India compared to the West. So in India, when you plan to take up orthopedic residency, you start off after your MBBS, after a year of rotatory internship. That is when you write an exam, or through other channels, you can get a seat in orthopedic surgery, where you will be either doing an MS orthopedics, which is a Master of Surgery in Orthopedics, or a DNB, which is a Diploma of National Board. These are the two ways where you can get your training in India, and the training is for 3 years. In the 3 years, you would be going through all specialities, all subspecialties related to orthopedics, and once you are out of this 2-3 years, you get a formal examination done by the senior colleagues and senior people, and who decide whether you are going to be a full-fledged orthopedic surgeon and you can enter practice. And this is the amount of training that we get in India.
Correct.
Now, what do you feel about the Western practice?
See, it's very different, right? So, when you think about orthopedic surgery, we are dealing with bones, joints, ligaments, muscles, a lot of things. We have 206 bones and a number of muscles, thousands of muscles. And if you go back 2 decades ago, the practice was a bit limited to mainly trauma orthopedic practice.
True.
But now it has changed significantly. We have so much of elective surgery we are doing. Not every joint we got a specialty, no subspecialty. So the amount of training we get now is like what it's required 30 years ago, maybe. But is it adequate? I don't think it is adequate. 3 years of orthopedic surgery and 2 years of diploma is probably not giving adequate exposure to the different kind of ailments in the bones and joints. And probably in the Western world, if you think about UK, post MBBS, they start off with a foundation program for a couple of years, then they go for a core training for 3 years. So they spent already 5 years after the MBBS exam, and still they are not an orthopedic surgeon. After the 5 years, they start off with the specialty training in orthopedics, and that extends for another 5 years.
It's a lot of training
compared to what we get
scenario.
Here. So, and if you think about the US, there after the medicine, they'll do have the internship, and then they go into residency program. Again, the residency program in US is 5 years. The same thing happens in Australia. So, rest of the world, the orthopedic surgery, the training itself is around 5 years. And I think that gives you a lot of exposure compared to currently what we are getting here.
Right.
And that is one of the reasons why lot of our juniors who are doing orthopedic surgery need to get trained in fellowships. And
So-
again, what do you think about the variance in the institute where they're trained? Again, that is different, right?
That definitely plays a very key role.
Absolutely.
One, in a way that the way they see things is different. Like you work in a private setup where you are not exposed to much of the caseload or the outside scenario. Your thinking process also would be limited. You would not like to explore more in orthopedics. But when you go to high volume center where you do good amount of cases, see a lot of cases, your approach would be different. You would like to further continue your training and improve your skills. So that is one thing. Also, these days even in India, we have a lot of fellowship programs.
Correct.
Which are specialized for these subspecialty practices. Now in orthopedics, if we speak, we have a lot of subspecialties. We have spine, we have knee, we have scopy, we have hand surgery, and we have even trauma fellowships, a separate 2-year fellowship program post your MS or DNB.
Correct.
So we have a lot of fellowship programs which have come in India as well. But definitely the place you work should be a high volume center where you do good quality work.
I might differ on high volume. I would rather put where you get adequate exposure and a quality kind training which is a bit more structured.
Right.
See, it is not just like going into a training program and get whatever you see.
Right.
That is not the case.
Yeah.
You need to have a certain, if you look at DNB, it is a very nicely put out structure. But how far the DNBs are following that is the question. Is it followed in those who are doing MS orthopedics in their post-graduation? We don't know.
Right.
So logbooks are maintained, but there is no set criteria or how they're defined.
Right.
So a logbook can be just, I can write down 10 pages and I can say I've done this or I have got exposure to this.
Right.
Probably there should be more objectivity for the training. Then the quality of the training they get will be better. And when they come out of the training, if they get on to their fellowship, any fellowship program, then they have a better approach to what they're going to do in the future.
Right.
Either because we are dealing with people here and you want to be safe, you want to be efficient, you should not be commercialized. Okay, it's not a business for us. It should be more passionate.
Right.
That makes a big difference in how the outcomes of the procedures we do, how we treat the patient.
Right.
So for me, the training should be a little bit more structured and it should be more objective rather than subjective.
So now, if I suppose I am an MBBS graduate and I want to take up orthopedics, I did my MBBS from India. So how do you guide me? How do I start off with? Whether should I choose training in India, whether I should choose a training somewhere else, and how should my further training be after orthopedics?
See, it all depends upon what you're looking for in next, say, 10 years down the line.
Right.
Okay, that's where I start.
Right.
So if I'm passionate, I want to do orthopedics only.
Right.
My starting point will be 10 years down the line where I want to be. If I want to be in India, because we have so much of volume, caseload, and we see more variety than anywhere else in the world.
True. Very true.
Right? So we don't have to really go anywhere out to get trained. We can get the same training here, but I would do in a more structured way. So either I can go for MS or I can go for DNB. But if I'm choosing MS, I will choose a good institute which has a good reputation, where there are all the subspecialties practiced. It is not just a trauma center I want to go to. I want to go to an institute where I can see orthopedic elective surgery like joint replacements. I would like to see sports medicine. I would like to do spine surgeries. I would like to see high-end complex trauma. If that institute covers all these along with general trauma, I think that will be the best bet.
Yes.
And the same criteria applies to a DNB as well. A DNB can choose a program or hospital where all these are practiced.
Right.
you should not be just a ward monkey.
Right.
Okay, once you get into a specific training,
Yeah.
I would like to be taught or trained.
Right.
You don't have to be handheld. At least there should be certain protocol-based,
Right.
objective assessment-based training.
Right.
So this is what I would look at. Do you
Also,
think that will be better?
Yeah, definitely. Also, as you also mentioned, if you are exposed to those subspecialty training in your training period, that is when you can develop interest in it, because a naive MBBS graduate won't be having an idea of the scope of a spine surgery or a knee replacement surgery per se. So if they get exposed to those sort of subspecialty practice during their training, that is when they can develop further passion in that, and then they can pursue further training.
Certainly. That makes a big difference, right? Rather than going in and around doing bits and pieces.
Yes.
Then you got to do your basic training in orthopedic surgery.
Right.
After that, you develop a subspecialty interest.
Right.
And once you develop a subspecialty interest, then you look for a fellowship program.
Right.
And the fellowship program should be such that at least it should be a year or 2 years of program.
Right.
A lot of the times we see 6 months or 3 months fellowship programs. I don't think this will give adequate exposure, because as a fellow, you need to have good hands-on, right?
Right.
If you're not getting good hands-on,
Right.
and you're not seeing a variety of cases,
Right.
then your fellowship doesn't have any meaning.
Right.
So if you really have to have a good fellowship or trained fellowship program, at least I would expect a year of program,
Right.
or if not 2 years, because we do only 3 years in orthopedic surgery
Right.
here.
Right.
So 2 years of fellowship
Yeah.
will make you a gem in whichever subspecialty you want to practice.
Right. Right.
So that 2 years you can do 1 year in one place and another in another place. Or for example, you can do 1 year in India and plan a year out of the country,
Yeah.
because that will change your perspective of how the rest of the world
Right.
trains you.
Right.
Okay, so you have a base of orthopedics, then you have a subspecialty in the fellowship in India,
Right.
and then you could go for a fellowship and across the world.
Right.
The other way of doing it is like you did.
Right.
So you do your medicine, orthopedics,
Right.
and then go out,
Yeah.
get trained, and come back.
Yes. Yeah.
So, and when I think about my own career, yes, I went off immediately after post graduation. Then I got trained there.
Okay.
I went up to the consultant level, and then I came back. So
Right.
that is another way of doing it.
Right.
But what depends, what makes a difference is, your start point. You need to know where you want to end up with. Okay, if you have an idea about that, then you can tailor your training accordingly.
Right.
Because unless you have that goal in mind, you go around like a headless chicken. You don't want to do that.
Yeah. Now that we now suppose that a person had completed his subspecialty training now, so how should he choose which place to opt for? Where should he start his practice? Are there any guidances from people like you, or
You tell me about your story. How did you do it?
yeah? So as everybody knows, India is a competitive place. To get into an orthopedic residency is a tough time, right? To complete your training is tougher. To get into subspecialty practice, I mean, if you talk about me, we have an exam to enter into subspecialty training called an FNB, which is a fellowship in national board, right? Many people apply, but only the top 10-15 people get into subspecialty training if you talk about spine surgery. So that is a very little number compared to the number of postgraduates outside, right? So it's a tough time to get into your this thing. So once you are out of your training period, now you have become a confident spine surgeon. Now then comes, where should you start your practice, right? There are a few options. One, you join off a medical college. One, you join a corporate hospital, or you go into a town and settle, right? These are the basic 3 options we have. So if you join a medical college, would you be able to pursue your passion? Would you be able to restrict yourself to spine surgery?
Yeah.
Is one thing, right? If you go into a town, it is difficult for you to restrict yourself to a subspecialty. You need to see everybody.
Absolutely.
You would be spending a lot of time in the outpatient department rather than your surgery. So a corporate setup would be an ideal place to start a subspecialty training, according to me. That is how I landed up here. Or do you say?
That really makes sense, right?
Right.
See, if you, that's where my starting point is.
Right.
Where do you want to end up 10 years down the line?
Right.
If I'm going to go to a town,
Right.
see, a lot of us, those who come from towns, you want to go back to your home place, and that makes your life much easier
Right.
to set a practice.
Yes.
Right. So if you want to go into a town, I don't see a big point in doing subspecialty practice.
Deeper training into
Deeper
something.
training
yeah,
into
yeah.
something.
Yeah.
Then you need to get your basic
General.
and you can get a gist of how each other specialty works,
Right.
and then you can start like a broad-based practice.
Right.
But if you want to end up in a metropolitan city,
Mm.
yes, here, if I want to be a general orthopod, I don't think I'll survive. So I need to have definitely a subspecialty practice.
Yeah.
So that is how I would probably put myself through.
Yes.
So how I can train myself and how I can set up a practice.
Right.
Yes, for me, when I plan to move back to India, certainly Hyderabad is my hometown and I would love to be here.
Right.
I would not go anywhere else.
Right.
So when I came back, then I had looked at the different options.
Mhm.
As you said,
Mhm.
you can go into a medical college. Again, because of the amount of experience I have, I may be limited with my skills there, what I can use there, my
Right.
skills wise.
Right.
So that's why I didn't go into a medical college. But I do go now and then to teach the postgraduates, and that we can do anytime.
Yes.
The second thing was to set up your own practice.
Mm.
Again, when you do a subspecialty practice,
Mm.
to set up your own practice, again, it becomes a cone or a tunnel view, and it is not that easy. You need to definitely have
A
other
team of people.
and all that.
Yeah.
So I didn't want to. But luckily, we have a lot of corporate hospitals here,
Mm.
which provide you that system available.
Right.
So that's where I joined AIG, where we have a team of surgeons.
Right.
Like we are at AIG, we are doing subspecialty practice
Right.
only, just like any other practice in the rest of the world.
Right.
So that's what we are proud about.
Yes.
So we limit everyone to our subspecialty practice.
Yes. Yeah.
Like we have sports surgeon like me, joint replacement surgeon. We have Dr. Rajesh as our foot and ankle surgeon, joint replacement sports surgeon.
Yeah.
Dr. Harshad does the shoulder surgery,
Right.
and Dr. Avinash does the hand surgery,
Right.
and we also doing spine.
Right.
So that way we can cover the whole spectrum of musculoskeletal problems and bone and joint problems.
Yes. Yes.
That makes a big difference in how a orthopedic practice develops and how we can cater to the population.
Yes.
So I feel very good about the way we shaped up, and I think that's what I would urge the rest of the guys to do.
So we now talked about how we landed up there. Now, talking from a patient's perspective, how much of a difference would a subspecialty practice help the patient?
Of course, that is a big thing, right, for the patients to know. I think, see, if you look at the current trend, how the social media marketing is going on,
Yeah.
too much of complex stuff is put on
Yes.
the social media, which confuses
Yeah.
a general person, a
Yes.
normal
Yes.
person
Yes.
who doesn't have much medical knowledge.
Right.
So it is not easy. If you think about the Western world again, because we're comparing, because there's a system set up there.
Right.
There, the patient goes to a general practitioner or a family practitioner. The family practitioner sees and he will decide whether this is a common problem or a complex problem.
Right.
If it's a common problem which any general orthopod can deal, they can go to the general orthopedic surgeon, a local guys. But if it's a complex problem and if it is a specific area related, like for example spine, they can come and see you.
Right.
Knee or hip, they can come to me.
Yeah.
If it is a shoulder problem, you can go to a shoulder surgeon. Like that, the part specific specialties have
Right.
developed.
Right.
So depending on the complexity and severity of the problem, they can visit the doctors who are specialized in that.
Right.
And definitely when they go onto the web, they can see a lot of names, and they can choose depending on where the person is trained, how is their practice,
Right.
and a lot of them, usually patient to patient referrals come through.
Right.
I think that is the best way of knowing a doctor.
So there is a strong referral pathway which is already established there,
Correct.
through which the patient goes through,
Correct.
and How about approaching a specialist? How easy is it in India compared to the Western?
I think we are very fortunate in India. Okay.
Yeah.
To see me, the patient can book an appointment maybe yesterday or a couple of days before and come and see me.
Yeah.
When I was in UK as a consultant, my outpatient waiting time was around 24 weeks.
Mm.
So to see me about a knee problem,
Okay.
the patient has to wait
4
for
months.
Correct.
Close to 4 months.
And surgery waiting time was around a year.
Oh.
After the COVID, I think it has even worsened in UK.
Mm.
In US also, there is again a lot of delays in getting the outpatient appointment. It can take around 6 to 8 weeks, and getting into the surgery maybe around 3 to 6 months. And even for getting a scan in the Western world, it can take a long time.
That is why we very often see in AIG that people come from the US and UK,
Correct.
get
Correct.
their scans done here, get an opinion, and
Get
go
the
back
treatment.
there. Quickly,
Even they
as
are coming
quickly
for the
before
treatment
they,
as well.
Yeah.
Like, so there are a lot of patients who are treated now.
Right.
So yes, healthcare, the access to the healthcare and the quality of the care and the cost.
Yeah.
Okay, so these are three important things:
Yes.
the access, quality, and the cost.
Mhm.
All of these are pretty good in our country. So that keeps us apart compared to the Western world. So we are trained well. We can deal with any complex problem because that subspecialty focused fellowship training has brought us to this level.
Right.
So I think that's what our junior guys who are coming into the specialty should try to do.
Right.
That way they will have a safer practice and they can be very efficient and get good outcomes with the surgical practice.
Very true. Very true. So, how does a patient? I mean, what qualities does a patient have to see in a doctor to decide that he is the guy?
That's a very difficult question, right? Yes,
Yeah.
it is so confusing for the patient
Right. Because
everybody
of the,
can be a super surgeon in our country.
Yes. So with the amount of social media marketing, as you mentioned, and the number of people around, the easy access to people,
Right.
they have a lot of options. But then they'll have to choose the right guy to get the best outcome.
So if you look at there are a lot of actually interesting studies done on
Mm-hmm.
how to find a good doctor.
Okay.
Okay.
Uh-huh.
So one thing is a patient to patient.
Right.
Okay. A patient who has been treated
Right.
by this particular doctor, for example, me.
Right.
Okay. That patient can give a reference to someone that this doctor is good.
Right.
This doctor will see you, gives you good time.
Right.
You have to spend good time.
Mm-hmm.
Not too much of waiting.
Mm-hmm.
Unfortunately, we can't watch on the waiting in our
Yes.
country because we do get a lot of walk-ins and that will destroy your the appointment times.
Yes.
And certainly in medical field, it's not like I can fix the car
Right.
in this much time.
Yeah.
So a patient comes, every person is different.
Right.
The person taking time for a problem, the same problem, person X can take 5 minutes,
Yes.
person Y can take 15
Yes.
minutes.
Yeah.
Okay, so like that. So giving time to the patient,
Mhm.
not too much of waiting,
Mhm.
not commercial,
Mhm.
okay, not jumping into surgery every time, and having good outcomes,
Mhm.
low complications, availability,
Mhm.
and having working in a team.
Right.
I think all these things will give I would say, all the good qualities of a good surgeon. Not only giving the good time, the time should be spent in such a way that you have to explain what is the problem
Right.
and how we can deal with the problem, what are the options, how we are going to get confirmation of a problem. Like for example, simple example, knee arthritis.
Mhm.
If I have to find a knee arthritis, a simple X-ray after examination would be adequate, right?
Right. Yeah.
But if it is something like in a young guy coming with a persistent knee pain,
Yes.
it can be many other things. It can
Yes.
be a cartilage damage, it can be a ligament damage.
Right.
Then again, I need to do simple X-ray after the examination. Then he may need a MRI scan,
Right.
and based on that, then we plan the treatment.
Yeah.
Treatment can be Not always surgery. Only 30% of the patients we see may need surgery. 70% of the patients can be treated without surgery. So, what is that patient? Who is that patient who needs surgery? That is how you should be able to tell the patient, this is the reason why you need a surgery. This is the reason why you can be treated without the surgery. If I treat with surgery, these are the outcomes. If I don't treat with surgery, these are the outcomes. So, by the time the patient goes out of your consult, the patient should be having a clear idea of what the problem they have, how they can be diagnosed, what investigations they need, what are the treatment options, and what are the outcomes, what are the realistic outcomes. So these are the important things. If a doctor can give all these details in the given time, and if the patient has any problems, they can come back and ask. If they have that accessibility to the doctor, I think that is a good doctor. It is not just the number. A lot of the social media you see, I've done these many numbers, hundreds, thousands. As a doctor, I'm also human. Okay, I can do only limited number of procedures. I can see limited number of patients. If I'm seeing 100 patients a day, I can give time to the patient. So that's why I limit my number to around 25 to 30 in a full day. That's when I can give good time to the patient, explaining everything. Surgeries wise, again, if you look at research, more than 5 or 6 surgeries in a day done by a surgeon is going to be the risk of having complications are more. So you got to be fresh. Okay, you got to be focused. You got to be efficient. Right. You can't take any chance. And for my practice, for example, I'll tell you what we did in UK or US. We used to have separate days for the outpatients and separate days for the surgeries. I do the same thing now. So that's what we are practicing in AIG. So that's where I think the quality care matters. When you're in outpatient, you can give full time to the patient. You don't have to think about what's happening in the theater. Is the theater ready or not? Who's there in the theater? Who's helping me in the theater? Who's anesthetic? We don't have to really bother about that. When you're in surgery, you don't have to bother about what's happening in the OP. So I just focus on the surgeries. I'll make sure that the patient is safe. Surgery is done perfectly. Here I should be a perfectionist. In surgery, I'll be a perfectionist. Only then we get the patient out of the theater. So that kind of a practice makes a difference. So we see a lot of doctors doing theaters, running into the outpatient, coming back into theaters. That is putting a lot of stress. If you look at the recent article, the stress rate in the doctors is highest compared to the general population in India. And the mortality, the lifespan, how much do you think now? In the
doctors are dying early.
So the lifespan in India, the doctors, is around 55 to 60 years. Average life. Horrible, right?